Hello, good afternoon, and welcome to this webinar, a new word that I have recently learned. I want to thank ORDESA for inviting me to give this talk. I am going to talk about the evolution of artificial formula of baby feeding over the last 200 years. So I've called it from the wet nursing to the neo-infant formula. I am a pediatric gastroenterologist from Bilbao. Bilbao is a 1 million inhabitant city lying on the north coast of Spain in the western corner of Europe, right south from UK, and weather here is about the same as it is in southern England. As you can see now from the window, today we've had a very nice day, as a sunny day, but this is not the most current kind of weather we have here. As I told you before, it usually rains a lot and it's very often cloudy. So let's go for the presentation. The composition of cow's milk and human milk is pretty different. There are quantitative differences. For example, human milk has less proteins, that cow's milk has more carbohydrates, basically lactose, and also has less ash than cow's milk and other animals' milk. But it's not only a question of quantitative composition, but also the qualitative composition. Because if we look at the proteins, the content of casein in human milk is much lower than it is in cow's milk. And the content of whey proteins, although similar, the kind of whey proteins human milk has is different from the kind of whey proteins cow's milk has. Human whey proteins are basically alpha-lactoalbumin, and that has no content at all of beta-lactoglobulin. And on the other hand, cow's milk has a high content of beta-lactoglobulin. And although fat composition is similar from the point of view of amount of fat, the composition of those fats are very different, as we will see later. The other thing we have to take into account is that the mothers that after delivery, when they breastfed their children, the delivery has been 2 weeks ago, 2 months ago, 6 months ago, or 2 years ago, perhaps. But the cows that are used to produce milk, although well nourished, very often they are cows that have been producing milk not only for months, but sometimes for years. It makes that because the milk changes along the lactancy, so it's not the same only the difference between the colostrum and the milk produced by mom during the first weeks of life, but also along the months, the milk composition changes a lot. So it makes that, although they look very similar, cow's milk and human milk are pretty different. So the aim of artificial formula, of infant formula, the aim for the last 150 years has been to become more and more similar to human milk, without this aim having been achieved yet. If we go back to history, at the beginning of the 19th century, they basically were 3 ways to feed the newborn or the infants. One was maternal breastfeeding. Is the picture you can see on the bottom left. This was the usual way to feed the children. In wealthy families, when the baby became an orphan, and in the case of wealthy families, when they could engage women to feed their children, as you can see here in the picture in the middle. For example, this looks to be a black slave feeding a white child, while his own child is lying on the floor. So among wealthy families, it was pretty common to engage what was called a wet nurse to feed their children, their infants, with human milk. But in the case that there wasn't an aunt able to take care of the new infant, or in the case of poor family, when the mom died during the delivery, the usual option was to use other animals or other mammals' milk mixed with common products of the area, like bread, like potato, carrots, or whatever. And it was really catastrophic. Most of these children who were not fed by their moms or by wet nurses, most of them, they would die from infection, dehydration during the first year of life, because the composition of the milk was not very similar to human milk, and because of the risk of infection, because of the manipulation of such preparations of mammal's milk mixed with other foods, available foods. So by the end of the 19th century, well, a few years before, in 1845, an English engineer working in India, he was able to, working with rubber, he was able to produce the first rubber nipple that facilitated a lot the bottle feeding of children fed on bottle feeding. But a few years later, by the end of the 19th century, the development of chemistry had allowed to know the differences between cow's milk and human milk. So in order to decrease the amount of proteins, because it was discovered that this was one of the reasons of frequent dehydration in children who were fed with cow's milk, they would add water to cow's milk. And in order to increase the lack of energy, of kilocalories that the addition of water produces in cow's milk, they would add sugar or honey. And in order to increase the amount of fat, they would add cream, milk cream. So like this, in a way, they were able to reduce the amount of proteins from 3 to 1%, to increase the amount of carbohydrates from 4 to 7%, and to maintain the amount of fat in this formula milk around 3.5% by adding cream. But the problem with this milk that was produced by old cows was that very, very often those children fed with this percentage method formula, they suffered from scurvy and rickets. So by the end of the century, of the 19th century, they would start adding orange juice in order to provide C vitamin, and cod oil in order to provide vitamin D, in order to reduce both scurvy and rickets. So, but until this time, until the end of the 19th century, all this manipulation of cow's milk, adding water and honey and sugar and cream and apple juice or orange juice and so on, was done in local pharmacies. It was really expensive and much time consuming. It didn't last a long time at home. So by the end of the century, there were some pharmacists and doctors who started to produce, after describing the composition of cow's milk and human milk, they started to produce their own pharmacy-made formula, but from a commercial point of view. For example, in Germany, Dr. Liebig, he put into the market a compound that was called the Liebig's soluble food for babies, that was theoretically the first available commercial formula for babies. In the States, a few years later, another doctor, another pharmacist, Dr. Richardson, produced a very similar product that was sold in the pharmacies, but already not in a local pharmacy made way, but in a commercial way. So produced by an industry. So by the end of the century, at the beginning of the 20th century, they were already commercialized formulas that were sold in the West, in Western Europe and in North America, ready for children whose mother weren't able to breastfeed them. It was a big development when in the 20s, in the 1920s, an American industry started to produce evaporated milk formula that was contained in cans, that was easily transported, that was very, very stable and was sterile, and that it was diluted with water by the local consumer, and it widespread the opportunity for breastfeeding children, as I said, first in the States and then in Europe. So this was really the first production of infant formula available for the whole, for countries or even for whole continents. In Europe, for example, we have Nestlé, who started to produce their infant formulas at the beginning of the 20th century. In the United States, Mead Johnson started to produce the same and to widespread the market through the country. But despite this development of artificial formula, in a paper published by the University of Wisconsin in 1915, they published that the mortality rate of children who were bottle-fed was much, much higher than the mortality rate of children who were breastfed. Especially if you look at the slides in summertime, basically due to infections, to contamination of bottle feeding with bacteria that led to diarrhea, to bacterial diarrhea, and an increase of death. And it was very, very, very significant. So in the 50s, with development of more development of chemistry, it was discovered that it wasn't just a matter of the amount of proteins, the amount of milk, or the amount of carbohydrates, but it was also discovered that the proteins of cow's milk were different from proteins of human milk, same with fat. So in the 50s, the infant formula industry started to produce infant formula that looked or were more like human milk than it was before. So it was done by removing mammals' oil from fat from the milk, and by adding vegetables in order to increase the amount of polyunsaturated fatty acids. They would try to reduce the amount of casein and increasing the amount of whey, and then once it was achieved in reducing the amount of beta-lactoglobulin and increasing the amount of alpha-lactoglobulin in order to improve the quality of the amino acids provided by the milk, and in order to reduce the risk or the prevalence of cow's milk allergy due to the high presence of casein and beta-lactoglobulin. So it was the beginning of adapted formula. But despite all these discoveries and advantages, it's well known, it has been well known that breastfed babies are less likely to develop enterocolitis, constipation, infant colic, regurgitation, allergy, diarrhea, obesity, and so on. So despite all this development, we can't say that we have still achieved in the industry of infant formula, the degree of imitation of human milk that we would like. So over the last 40 years or so, the industry, the infant formula industry, has started to add, imitating again human milk, other nutrients, other substances that had additional functions apart from nourishing apart from the caloric content. This is what we call functional components. So, and this is something that is not strange to us. It's something that it has been done by our moms and our grandmoms for centuries. When one had diarrhea, he was given rice. When one was constipated, he was given fruits or prunes. When one had diarrhea, was recommended to eat yogurt because there was something in yogurt that would improve diarrhea. And so these functional foods have been used for centuries by common people. So, and looking at the differences between cow's milk and human milk, we can see that proteins, although we have been able to reduce the amount of proteins in cow's milk from 3.5% to 1%. Still, the composition is as I said before, is quite different from the point of view of presence of casein, the different kinds of casein present, the presence of beta-lactoglobulin. We have also to take into account that as much as there are proteins in human milk, there is another carbohydrate that we have paid very few attention for the last 200 years, that are the oligosaccharides, the HMO, that they represent about 1% of the content of the milk, as much as proteins, as I said. And recently, many advantages related to those oligosaccharides have been discovered from the point of view of development of allergy, from the point of view of immune development of the gut, immune development of the child. And also, for many, many years, it has been thought that human milk was sterile. Human milk is not sterile. It doesn't mean that it's contaminated, but human milk contains probiotics, contains microbiome, contains bacteria that are good for the health of the baby, that are good for the development of the immune system of the baby, and also for the epigenetic development of the metabolic development of the baby. So over the last few years, all those compounds of human milk have been introduced in cow's milk in order to make new infant formulas more similar to human milk, and in order to reduce all those problems that I have mentioned before, like cow's milk allergy, constipation, diarrhea, a colicky baby, regurgitation, etc. So, for example, from the point of view of lipids, human milk has more oleic acid that cow's milk has more polyunsaturated fatty acid like DHA and EPI. And another important difference is in the triglycerides, the palmitic acid that in the cow is usually localized in alpha position. So if we look at the triglyceride like a fork, the palmitic acid is in the branches, in the external branches. In the case of human milk, the palmitic acid is localized in the middle branch of the triglyceride, and as I will explain later when we talk about constipation, it makes a difference. There are also, as I will mention later, many differences between the proteins, and not only the proteins, but the other compounds with nitrogen in human milk and peptides. I have just mentioned the presence of prebiotics in human milk, and I have also mentioned the presence of probiotics in human milk, that are the functional components that we are been adding for the last 20-30 years to infant formula in order to improve its quality. I will explain just for a few seconds what's the difference between fiber, soluble fiber, insoluble fiber, and a prebiotic. So all of them are carbohydrates. On the top you have sucrose, that is glucose with fructose. If you have one glucose in a chain with many fructose molecules, this is FOS, a FOS. If the chain is very, very, very long, this is inulin. And all those are carbohydrates that are not digested by the human being, apart from sucrose that it is, but the rest, the FOS and the inulin, is not digested by the human gut, but it is digested by our bacteria. So it means that when it arrives to our colon, it will be digested, and they will feed the bacteria in our colon. It will feed our microbiome. Starch is also a carbohydrate with a very, very long chain of glucoses and with branches of glucoses, and depending on the branches, it might be more or less soluble in water, and it will also depend on the temperature. So basically, I would say that insoluble fiber is that chain of carbohydrates that is not digested by the human being, neither by our microbiome. Soluble fiber are those carbohydrates that is not digested by the human being, but are digested by our bacteria, and then the disaccharides and the sugar or the starch are carbohydrates that are digested by the human being. And if there is malabsorption for any reason, for example, lactose malabsorption, they will be digested by the bacteria in the colon. Lectins is a kind of complex carbohydrate. It's like a mixture of soluble and insoluble fiber that has a lot of functions, especially by feeding the microbiome, and when it can be used for patients with diarrhea with good effect. When we look at the microbiome, the microbiome is not constant. It changes during life, and as you can see in this slice, the bifidobacteria are the predominant bacteria present at birth. Is the main bacteria, the main family of bacteria that are catched by the baby during the delivery, and is the dominating bacteria during the first 1, 2, 3 months of age. So when giving probiotics in an infant formula, it may have some sense to give other bacteria, but we have to say that, for example, lactobacillus is a bacteria that is predominant when the children are already 2 years of age. But the bacteria that is predominant in the gut of the newborn baby, on the baby who is 1 or 2 months of age, are bifidobacteria. Well, going again to the history of infant formula, we were in the adapted formula. We had substituted the fat of the cow's milk for vegetable oils. We had reduced the amount of casein. We had increased the percentage of alpha lactoalbumin, etc. And now, for the last 40 years, they have appeared what are called the therapeutic and the functional formula. For example, the formulas for cow's milk allergy, although the first one was produced in the 1930s, that was the soya formula. The extensively hydrolyzed cow's milk protein formula were developed in the 70s, and they arrived, for example, to Spain at the end of the 70s, at the beginning of the 80s. And for the last 10 or 15 years, the industry has been developing different infant formulas with specific components for constipation, reflux, diarrhea, etc., imitating always human milk. So basically, nowadays, normal infant formula for babies, they should have a higher content of whey proteins than of casein proteins, and especially of alpha-lactoalbumin. In order to imitate maternal milk, they should have a high percentage of palmitic acid in beta position, and they have to be rich in polyunsaturated fatty acid. They should also have oligosaccharides because they promote the development of a bifidogenic microbiome in the gut. For example, for the preterm infant, we would like to increase the caloric density of the milk from 67 kilocalories per 10 meals per 100 milliliters to 75, and in order to reduce the osmolarity, we can add these calories by adding maltodextrin that has a lower osmolarity than lactose has, and we can also add calories by adding MCTs that are very easily absorbed because they go directly to the blood, to the capillaries, to the veins, not passing by the lymphatic system and going directly to the venous system. So, for example, for reflux, if we increase the density of the milk with carrot bean flour or corn starch, it makes it more dense and more difficult to be regurgitated. For example, for colicky babies, who knows what infant colic is, but we know that they cry, and this is terrible for the families, and it may last for 1 week to several months. And it is thought that in some way there is some kind of inflammation going on. And so it seems to be a good idea to reduce the amount of lactose and change it with maltodextrin that allows to reduce the osmolarity of the milk, perhaps improving the symptoms, and in order to reduce the inflammation, the underlying inflammation, by adding bifidobacteria and prebiotics in order to, as I say, to reduce this inflammation. If we look at constipation, there is extant information nowadays that palmitic acid in beta position in the triglyceride improves, and I will explain later why it happens. We know that magnesium is a good physiosofter, and we know that the fiber, like FOS and inulin, by feeding the bifidogenic bacteria and by providing fiber, also facilitates the solution or the softening of the feces. So what's this of the alpha and beta position of the palmitic acid in the triacylglycerides? So cow's milk, in the cow's milk, the triglycerides, they have their palmitic acid in the alpha position. That it means it's in the external part of the triglyceride. When it is hydrolyzed in the gut, it reacts, the palmitic acid that is liberated from the triglyceride, remaining a monoglyceride and 2 palmitic acid, it reacts with the calcium, and calcium and an acid results in a soap, and this soap results in a mild reduction in the absorption of calcium and palmitic acid, but basically it results in an irritating substance in the colon of the baby that leads to constipation. So by changing the composition of the fat in infant formula, and by adding oleic acid and increasing the percentage of triglycerides with the palmitic acid in beta position, we will manage to provide a better quality milk with more oleic acid and a less irritating milk, because this palmitic acid in beta position won't be hydrolyzed in the gut, and it will be absorbed in the form of monoglyceride of palmitic acid, without resulting in the production of sops that will irritate the colon of the baby, and obviously it will reduce the constipation. As you can see in the next picture, it has been published, and there are many publications that confirm this reduction of the consistency of the feces by changing palmitic acid from alpha to beta position. So what about diarrhea? So although the American or the European Society for Pediatric Gastroenterology, they don't recommend for acute gastroenteritis removing straight away lactose. Obviously, if the child has been passing watery diarrhea for 4, 5, 6 days, it is sensible to reduce or to eliminate lactose, because it might be one of the main reasons for the persistence of diarrhea in an infant. So in formulas for diarrhea, they often have non-lactose at all, and it's changed by maltodextrin, that also has lower density, and it doesn't need the presence of lactase to digest it, or a low lactose formula with maltodextrin again, but without removing completely. We know that zinc is a mineral that has properties that reduces the diarrhea, and we also know that soluble fever reduces diarrhea, and we know that bifidobacterium, they also are able to reduce the inflammation and reduce the diarrhea, and there are specific publications about specific bifidobacteria that have been proved not only to reduce diarrhea, to reduce the inflammation, but specifically to reduce the capacity of replication of rotavirus, that is one of the main agents causing infant diarrhea. So here you have 2 papers. The first one is an in vitro study with bifidobacterium for the treatment of diarrhea. The second one is a clinical trial performed in infants with diarrhea, with a formula containing bifidobacteria and a formula not containing bifidobacteria. It has been proved that not only that the amount of viruses is reduced, but also that the diarrhea lasts shorter, and the rates of admission to hospital are also lower when children are fed with formula that contain bifidobacteria than when they are fed with formula that don't contain bifidobacteria. Here you have this is an in vitro study. It measures the amounts of rotavirus antigen with a formula containing bifidobacteria and a formula not containing bifidobacteria. Here you have the result. In red color is when the formula does not contain bifidobacteria. You can see that the ROC curve is higher. There are more viral antigens that in the yellow curve, when with the milk contains bifidobacterium, that the total amount of viruses is less, and the lasting of the diarrhea is also shorter. So, and what's next? What's next, or what was next? Because it is the future, but the future is already here. We know that there are many other proteins, and there are many other nitrogen-containing components in the milk. We know there is lactoferrin that has antibacterial or has bacteriostatic properties. We know that there is lysozyme. We know that there are immunoglobulins. We know that there is osteopontin. So we know that in human milk there are many proteins that have a specific properties for the development of the immune system, but also for the protection of the child from infections, etc., that in the next future they will be added to our infant formula. There also are peptides and other polypeptides and proteins that we don't still know what are they useful for. And there are even small pieces of RNA that are of unknown significance, but we now know that some of them interact with the lymphocytes of the gut, and they have huge importance in the development of the immune epigenetics of the baby. So, for example, in the 50s, it was discovered that the fat of the cow's milk was not the best for the baby because it's high content in saturated fatty acids and the lack of polyunsaturated fatty acids. But we have also discovered over the last 10 years that it's not only a matter of unsaturated or saturated fatty acid, but that the fat present in the human milk is not just fat like the olive oil or the butter when we have in a bottle or in a bag, but it forms a globule that has plenty of proteins with many different functions related also to immunity, to immunity regulation, etc. So in the next future, we will see a way back to add fat globules as a source of fat in infant formula, but still keeping the polyunsaturated fatty acids like DHA, EPA, etc., that are very important for development of the brain and in the immune system and for the balance of the inflammatory response of the baby and of the adult. So even endocannabinoids, we know that there are endocannabinoids in the human milk, and they are probably related. That's probably why children fed with human milk, they tend to be more calm. So it's probably related also to proteins. It's probably related also to the microbiome, to this bifidobacteria, but it's probably also related to those endocannabinoids. So we will probably see in the coming years that we might be adding endocannabinoids or cannabinoids mimicking the cannabinoids present in the human milk in order to convert or to make our infants more peaceful and to treat, for example, infant colic. So basically, as you've seen, the history of artificial feeding of infant formula has been the history of approaching cow's milk, and it has been cow's milk because it was developed in Western Europe and in the States, and the main farm animal we have is the cow. If it had been in the Arabian Peninsula, it would have been probably the camel. But because it was here, it was the cow. So the history of the last 150 years has been the history of trying to approach cow's milk to human milk by first changing the quantity, the quantitative composition of the milk, then changing the quality, and very recently, for the last 10-15 years, by adding components that until very recently we haven't paid very much attention to them. As I said, for example, the prebiotics, the probiotics, the fat globule, or in the next future, for example, the addition of osteopontin, of lactoferrin, of lysozyme, of endocannabinoids, in order always to try to make the infant formula as similar to human milk as possible. And that's all. Thank you very much for your attention. Now I will try to I will try to answer to some of the questions. So there was a question, how infant formula improves the immunity? Okay. For example, it would take too long to explain it, but for example, the prebiotics, it has been proved that the content of prebiotics of infant formula reduces the atopic trend among children taking these prebiotics. And the importance of prebiotics is that they fed specific bacteria, like for example, bifidobacteria, that have also proved that children who are breastfed are less likely to develop allergy, whistles, respiratory symptoms over the first year, the year of life. So prebiotics and probiotics, so human oligosaccharides and FOS, together with bifidobacteria, they are able to better prepare the lymphocytes of the infant in order not to go to a Th2 response, but to maintain an equilibrated response, and it has been largely proved. More questions? Well, there's a question here about Blemil Plus and COVID-19. I don't think there is enough evidence to recommend any specific infant formula for COVID. The only thing we know so far is that, fortunately for us pediatricians, COVID is affecting very, very, very little to infants, even to newborns. In my hospital, there have already been several deliveries in mothers who were suffering from COVID, and the children have not been infected, and nothing has happened with them or with their moms so far. So, but who knows? Perhaps. In premature babies, what is the better option, cow milk or formula? Well, cow milk never is an option in a premature baby. The best option, obviously, is human milk. We have banks of human milk that has been treated, so it lacks the property of prematurates that are breastfed, because they are breastfed with human milk with bifidobacteria and with its own microbiome. Obviously, if it goes to a bank of human milk, is sterile, but the best option for a premature baby is human milk. That is different in mothers who have delivered a premature baby than in moms who have delivered a term baby. So the breast of mom knows what's the most convenient milk for the baby. It's not the same. Obviously, if the milk of mom is not available and we don't have a bank of human milk, the best option is a specific milk for prematures, but never a mammal milk like cow's milk. Does palmitic acid formula cause demineralization of calcium? Not really. The calcium metabolism is very complex, and it depends on sun exposition, it depends on sport, it depends on the genes, it depends on your heritage, and obviously it also depends on the amount of calcium one might take. So it's it doesn't. The amount of calcium that is not going to be absorbed because of this saponification of the milk is very slow. So the most important is that it will irritate the terminal gut, the colon, and it might result by this irritation in constipation. But we cannot really say that a child who is fed with triglyceride that has palmitic acid in alpha position is going to have a bone of lesser quality than a child who's been fed with fat with palmitic acid in beta position. But obviously the total absorption will be higher. But as I said, it's so multifactorial, the metabolism of the calcium, that looking just at the absorption of or not absorption of calcium due to the saponification of the palmitic acid doesn't seem to be very important. So, more questions. Well, there is another question about enterocolitis I guess, in premature children. As I said before, the best option to avoid enterocolitis is human milk. If there is not human milk available directly from mom or from a bank of milk, it's the best option is a specific formula for preterm babies. As far as I know, there are no reviews. Well, there are reviews, but they are not conclusive on the Cochrane Library about probiotics for diarrhea. Not only from bifidobacteria, but there are many papers that have proved that probiotics are effective if they are used early. After the development of diarrhea. So let's say if an infant or a child develops diarrhea and one starts treating the child with probiotics 5 days after the child has been with diarrhea because it's not resolving, probably in that case, well, probably no, it has been proved that in that case the prescription of probiotics is useless. Probiotics have to be used during the first 48 hours of acute diarrhea. Basically, acute diarrhea caused by viral infection, and the main viral infection, at least in Europe, is rotavirus, although it's decreasing because of vaccination. But so basically, there is a paper published in the New England Journal of Medicine last year that said that there was no evidence that probiotics were good in reducing the length, the duration of diarrhea, but there are many papers that prove that the use of probiotics during the first 48 hours of acute diarrhea reduces the amount of feces, reduces the percentage of admission, and reduces the number of days of diarrhea. There is a question about how many years, for how many years does a cow is able to produce milk. I'm sorry, I'm not a veterinarian doctor, so no idea. But what I know is that the cows that are used, although to produce infant formula, although they are of the best quality, obviously they haven't just delivered their veal, and they are not used just for 6 months, so they are probably used longer. But I have no idea for how many years. Perhaps someone in the brand will be able to answer to that question. I don't know what's the average age of the cows producing the milk that is used to produce the infant formula. Why is not recommended in the first stage of infant formula? No, there is a question here. Why it is not recommended to add probiotics in the first stage infant formula? That's not correct. There was a recommendation years ago by ESGAN not to add probiotics for infants below the age of 6 months, but it has been proved that probiotics are even useful in preventing necrotizing enterocolitis in preterm babies. So it's not advised not to add probiotics in formulas in formulas for newborns. So there is nothing against it. So in the opposite, I would say that I would recommend that the initiation formulas have probiotics. So there is a question in Arabic. I'm sorry, I'm not able to understand Arabic. Well, I think I have answered to, as far as I've seen, I think I have answered to most of the questions, because some of the questions are very similar one to other. I think I've answered to most of the questions. If I find any other question, I will answer in the next seconds. So far, you can fulfill the survey that the brand has just asked you to fulfill. And thank you very, very much for your attention. And I hope we will be able to see each other, or to visit. I will be able to visit you in your own countries in the next future. Thank you very much.